This is the Healthcare Education Transformation Podcast, a podcast brought to you by two physical therapists devoted to helping physical therapists and other healthcare providers become better educators to patients, students, the community, and each other by interviewing prominent and passionate people within the realms of healthcare and education. The Healthcare Education Transformation Podcast is intended literally for educational and entertainment purposes only. No clinical decision making should be based on only one source, and therefore this podcast should not be used as personal medical advice. While care has been taken to ensure accuracy, occasionally mistakes and factual errors can be present, as we are only human. This is our journey on the road to becoming better educators, so get ready with your pen and paper as class is about to begin.
Hey everybody, this is Brandon from HET, and I'd like to take this time to make a very special announcement that we are welcoming a new co-host onto the show, as we are incredibly excited to have the one and only Dr. Stephanie Wyrock joining the HET team. As F. Scott and I believe that she'll be a tremendous asset to the team, so we give our biggest welcome to Stephanie. For our listeners, we currently have 18 episodes that F. Scott and I recorded previously, waiting to still be edited and released. However, Stephanie will be starting on the show with us this week, and we will continue to release our prior 18 episodes with releasing some of the newer episodes with her on the show. However, since we have a delay from when the recordings take place to when they're released, it will still be a few months before all of the current episodes with her involved will be present on the show. But without further ado, we present our discussion with Dr. Andrew Bennett. Welcome to another episode of the Healthcare Education Transformation Podcast. I'm one of your hosts, and I'm Brandon Powen, and as always, I'm joined by my other half, F. Scott Veal. And today we are very excited for this episode, as today we discuss the topic of effective clinical instruction from one of the best there is, Dr. Andrew Bennett. Now, before we get into that, I'd like to first give a personal shout out to our good friend Mark Milligan for recommending Dr. Bennett for this episode. Now, for those of you who don't know who Dr. Bennett is a co-founder and co-owner of Texas Physical Therapy Specialist. Andrew Bennett holds a clinical doctorate in physical therapy, is board certified in orthopedic physical therapy, and is a fellow in the American Academy of Orthopedic Manual Physical Therapy. Dr. Bennett was an Air Force physical therapist for several years before transitioning into private practice. Dr. Bennett has served as adjunct faculty, clinical faculty, and guest lectured for several physical therapy programs across the U.S. He currently provides clinical instruction into the Evidence in Motion Postgraduate Orthopedic Physical Therapy Residency and the Evidence in Motion Orthopedic Manual Physical Therapy Fellowship programs. He has been recognized for excellence in clinical education by the Texas Consortium and is a recipient of the Warren C. Smith Award in recognition of professional clinical and educational expertise, innovative delivery of care, commitment to physical therapy private practice, and community service. Additionally, he was chosen by the San Antonio Business Journal as a 2015 recipient of their 40 Under 40 Awards. Dr. Bennett and his wife Heather met while finishing their undergraduate training in physical therapy as classmates. Heather was instrumental in helping to establish Tex PTS and is now the CEO of the Bennett home and their 6 children. Now, Dr. Bennett, thank you so much for your service to the profession and for coming on the show today to talk with us. And I figured that I kept your bio pretty brief because I'm sure there's a lot more that you've done. But, was there anything that you'd like our audience to know about you that I didn't mention in this intro here?
Sure, Brandon. I think currently my favorite hobby is brewing beer and playing my guitar with my kids, trying to get a little bit more time with them as they're getting older.
Awesome. Andrew, what are some of the characteristics or prerequisites that a newer PT should possess before taking their first student? When is the right time?
Gosh, I don't know that there's ever a wrong time. I do think there are better times. There oftentimes in teaching, you're pretty passionate about what you've learned. You want to pass it on to the next generation of PTs that's fallen behind you. But being good at something and understanding how to teach it are two different things. I think, a couple of years in your own practice, particularly based on whichever setting you're in. I know, Brandon, we were talking about, getting kind of into the groove at a new location. Operationally, I think you need to have a good understanding of what the organization requires for you to thrive in order for you to be able to give some structure and format to a student that's following you. It doesn't mean you can't take a younger student and let them just kind of shadow and learn what it is you do. But if you're going to take on somebody in a longer term internship or certainly in a residency format, I really feel there's some structure that really seems to make that helpful. And so if you've got those in place and you're at a place in your job that allows you to build some extra time in, then I think I'm all for it, man. Just find a willing body and start.
Yeah, that's really good to hear. And I know for sure there's another avenue that a lot of people, myself included, have gone to kind of learn about the process and kind of get better at it. So Scott and I did the APTA CI credentialing course a few months back because we wanted to become CIs and we thought learning from this other avenue would be a good start. But, I'm kind of curious, what are your thoughts on the APTA CI credentialing course as a first start for someone who's looking to be a clinical instructor?
As with all things, the APTA is really a good resource. I will tell you that my personal bias is not to go to the APTA for the expectation of the best and pushing the tip of the spear, right? I mean, that's typically what we find in other organizations. But the APTA, in my mind, is one of those things that says this is the bare minimum. If you're not doing at least this, then you really should reconsider. My personal belief is the APTA should be not pushing the front of our profession, but they should be lopping off the back end, right? In other words, it takes innovators, it takes thinkers, it takes progressive people, and a structure like the APTA isn't built for that. But what the APTA can do is they can lop off the bottom end of those folks in the profession that aren't willing or aren't ready to move forward in progression. So the APTA CI course, I think, is a good example of that, of saying, hey, if you haven't done at least this, then you're probably not ready to take on students. In terms of learning to be a CI, I think it's a good start, but I certainly don't think that's going to make people fantastic CIs if they've completed just that one course.
Yeah, I think that's a really good take on it. I actually took it because my company is just starting to take students this year, actually. And that was a prerequisite. If you wanted to have a student, you had to at least be CI credentialed. I mean, I've been practicing 11 years now, and I've had a handful of students in my career already. So, I felt pretty comfortable, but I definitely was okay with going to that course because I felt at the very least, like you said, it was a good foundation. And I think it was a good way to push things forward from there. And of course, I feel like there's a bit of a parallel, in patient care with first going through like an initial evaluation. As a mentor and educator, we really should evaluate where the mentee is, and kind of assess certain things. But could you walk us through how you initially evaluate a new student that has arrived at your clinic?
Yeah, I can. We typically will sit together and learn a bit about each other. My preference, my mentoring style is highly personal and highly future focused. So getting to know who they are and getting to know what drives them and what their desires are, but also getting to learn how they communicate verbally, non-verbally. And those are things that you can't obviously ask. Those are things you have to discover. You actually have to spend some time together in that environment. And then we will spend some time going through a bit of a mock case. One of the things I've learned to do is really just listen to how people think. So, let's come up with a basic scenario of a, pretty standard, low threatening, low back pain case, and then ask this young student, okay, you're walking into the room, what are the things that are needed for you to get into the objective exam? Well, I'll need this, and I need this, and I need to know the mechanism of this, and they'll ask a bunch of questions, and then I'll ask him, I said, okay, do you have enough? In other words, do you have enough to move into the objective exam? Well, I might need this, I might need that, and so what you're listening for is, are they confident? Do they have a process? Are they grasping at straws? Do they have did the things they asked for actually make sense? And then oftentimes you'll get to a point where they'll exhaust their own uncomfortableness with not knowing and flat out say, I think I am or I'm not. And then you'll move towards the objective exam. And in the objective exam, a similar approach of like, well, what is it that you need in order to begin intervention? And so it gives you a chance in a very non-typical situation for you to actually look and hear what it is they're thinking. I think that's probably what makes better encounters I've had with students is when I can build a relationship with the student or the resident, and you can begin to see and hear what it is they think rather than what they think you want to hear, so that you're able to guide them forward. So I think spending time getting to know their communication strategies, and then how and where are they in their own thinking.
Yeah, no, that's a really good take on there, Andrew. And on average, do you guys normally spend like the first day doing that, or does that kind of go throughout the course of a week? Or because I realize too that in the clinic sometimes time might be a factor.
Yeah, so with a PT student, I usually take the first 4 hours of the day. So in other words, when I've got not a resident who's a licensed therapist, but when I've got a PT student, I really feel like you get what you pay for. Right? I mean, if you expect them just to jump on your hip and follow you around for, and not really have time to build relationship or build communication strategies, then you're going to be kind of playing catch up the whole time. But not every situation's set up like that. I've had several students myself where I have, based on clinical volume, and somebody was out of town and I had to cover, it just didn't work. So we did it, after clinic that first day. We stayed and went and, grabbed a couple of tacos and kind of dove into learning that direction. But I do feel like that first week is really critical, particularly if you're, someone who's got a longer internship, 6-9 months or whatever they're there for. But yeah, so typically my format has been to get to know them initially, identify kind of who they are. We use a pretty kind of imagined best self approach. So I have them actually physically write down for me a paragraph that answers this question. At the end of my internship, I will look back and say it was an overwhelming success because, and then I ask them to fill in the blank. And we go back and revisit that several times throughout the internship. But that's another thing that happens in that first day. And then throughout the rest of the first week, we set some pretty established benchmarks. There's a structure for historical exam, hypothesis-based reasoning. We talk about building a standardized upper quarter and lower quarter examination for their physical exam, so that we have some common knowledge between the two of us of how that process works, and where are they proficiently through that, so that we can begin to expand their independence in the clinic.
Yeah, I love that take on that, Andrew. What are your thoughts on using the Socratic method when encouraging self-reflection with students?
Yeah, it depends on if they're capable of thinking for themselves. And I don't say that in a derogatory sense. I mean, really, most of the students who come out of school have not been taught how to think. I mean, they've been given, a very structured, undergrad degree where this is what you're expected to learn, this is what you're expected to pass, go take this test, now go to the next one. And then PT school is certainly no different. Here's your anatomy, here's your physiology, here's your gait and biomechanics, go learn this, here's the test, here's the right, and we're taught all through that there's a right answer. And if we don't get the right answer, then we're wrong. And the reality is, when we look at patient care, rarely is there actually a right answer. More common than not, there isn't one. And so you talk about self-reflection. I think one of the things that I typically will use self-reflection for is coaching and mentoring them into how to think. So is the Socratic method helpful? Yes, because it helps teach them how to think. Once they've learned to have some chops and being able to do that, then we can facilitate actually some feedback around their self-reflection.
Yeah, no, I think that's a really important point. I especially think I agree developing that self-awareness is so critical. And something that I'm going to back up on here, Andrew, because I know this is something that definitely comes up with dealing with a student or a resident for sure. But with all clinical education, there are several times that involve providing feedback, as sometimes self-reflection does have limitations, both to provide positive feedback, but also to give kind of that tough advice perspective at times to really push that mentee or student to that next level of development or learning. And, I realize that this depends on the individual and the contact, and there's a lot of other things involved with this answer. But how and when would you recommend providing constructive feedback to a student?
When are you not, right? That's I hear your question of is there formal time to sit down, and then, how do we build that into the process? Part of it comes from establishing expectations in the beginning. I've long believed that the student, again, we're talking PT students, not necessarily residents, but the student needs to earn the right to be taught. And that's, I've had many students who I'm excited about and want to just give lots of feedback to, and yet they really are either incapable of receiving that or flat out unwilling. So my approach has become, a student needs to earn my time, and needs to earn the right for feedback, needs to earn the right for instruction. And the way they do that is to provide support to me, their mentor in the clinic, to give me more time in my day. And whatever time that they help facilitate in my day, they earn towards their own input. I'll give you a perfect example. The first thing the students do is they learn to write my note, right? Here's how I'm going to have you do this. This is what I want my daily note to look like. It says this, it says this, it says this. And we actually have a structured format for daily notes that make it very, very simple. So then I end up not having to write my daily notes, or I'll sit in with the new eval and I'll say, okay, here's my body chart, here's my P's, here's how this works. Go write my daily note or my eval note, and they'll disappear. Now, part of it is they've been through the process with me enough times that they understand it, right? So you're not asking someone to do something you haven't outlined the process for. But once they get it, now they're actually it's being modeled for them, and they're actually, through writing, beginning to put clinical reasoning in place. And it's a bit of a sleight of hand. They don't know that they're actually typing out what you're thinking, and that becomes what they think. But the process also evolves, and now instead of me having to write these darn daily notes every day, my students writing them out. And at the end of the day, we've got time together, or we've got time after the morning, because, we saw 10 patients this morning, but 8 out of the 10 notes are written. I can bang out 2, and we've got an hour and a half now that we can sit down and work. So I think part of the process is, when do you give feedback, is when have they earned it? When have they earned the right to be given your instruction? Now, clearly there are baseline norms that need to be covered, and I'm not saying that you be a miser, withhold from them, but there needs to be the expectation that, hey, I want to give you what I have. Here's the pathway. Here's the hurdle you've got to get over to be able to learn. And then, in terms of direct feedback, there's got to be an understanding that I'm going to provide you feedback, and it's going to be your choice as to whether we go to round 2. And that can be pretty tough to do.
Yeah, no, for sure. And I think that's a really good take, and that's something that I actually hadn't thought of, but I think that really makes sense to really kind of set that expectation and really kind of help them get into your clinical reasoning, kind of get them into your thought process, so they're seeing that more. And then by opening up your time, you're able to really devote to them if they work at it. So I think that's actually a very good point. And, I'm going to kind of go one extreme here. So Andrew, how would you recommend guiding the student who's struggling in the clinic?
Well, I think you have to first pause and identify what it is they're struggling with. Are they struggling with clinical content? For example, do they not know their anatomy? Do they not know the special tests required in the objective exam? If it's a baseline knowledge issue, then that's something you'll have to address with, again, expectations, right? So it appears to me we've discovered that you don't have a working knowledge of your knee special tests. In order for us to be able to move forward, you have to. What do you suppose is an appropriate timeline, and for you to be able to come back and see you perform XYZ tests? Well, let's do it in 3 days. Okay. Do you have the resources, videos, books, whatever that you need, or do you need additional help from me? Right? So you identify the struggling specifics. You allow them to put realistic timelines around it. You may have to support those or guide them a little bit in that. But then they have to own their own results. Do they have the resources necessary? Do they need more resources for you? And if they don't, my thought here is, if they don't have responsibility for their own learning, then it becomes a huge time sink and energy sink from you, the CI. But to put them in a position of, where they are responsible for that learning. Now, that's if it's a clinical thing. Oftentimes, ironically, it's not the clinical stuff that they're struggling with. Oftentimes, it's their inability to be honest with themselves, their inability to recognize that their own mind, their own emotions tend to master them rather than the other way around, or they're so afraid of being wrong that they back themselves into a corner, and they are unwilling to be honest with themselves and state I don't know, or state what they do know, and unable to back that up and say and just be comfortable with being wrong. One of the things that I use routinely with my students is it's a game. I was like 8 years old, learning to play it with a friend of mine. It's called Mastermind. I think there's a bunch of knockoff versions of it online now called Code Breaker, but it's essentially a row of 5 pegs and a bunch of different colors, and you're trying to put the pegs in the right color to guess the hidden sequence of colors behind the screen. You have 10 times to try and get it. And essentially, we use this game to say, hey, there's a right answer behind this. I want you to guess the right answer. And they would spend multiple times trying to get the right answer, and they would never get it right, because there's a process for providing feedback on that, whether the colors they're right or it's the wrong color but in the right place, that type of thing. And then I teach them how to systematically be wrong. And by systematically being wrong, you can win that game every single time. And so part of, giving feedback to a student may be teaching them how to be systematically wrong, teaching them how to be in integrity with their own thinking, and being okay with what they're thinking not being right. The analogy we'll often use is, it's very, very hard to steer a vehicle or a boat if it's sitting still. Right? You've got to be in motion. I don't care if your car's going 70 miles an hour headed straight for a tree. If it is, it's really easy to get it back on the right path. It just takes a little nudge of the steering wheel. But if you're sitting still or going 5 miles an hour, it's very difficult to change directions. So I just encourage those guys, let's work on being systematically wrong. Let's work on being in integrity with yourself and understanding that it is okay to be honest. I would prefer honesty way beyond smarts. I truly believe that learning cannot exist in the absence of honesty.
Yeah, those are some great analogies, Andrew. My brother and I used to play that game for hours, and I used to love that one. But let's go to the other end of the spectrum. How would you recommend guiding the exceptionally gifted student, maybe the student that's pretty far advanced in their studies?
Scott, ironically, the same way. Again, they may have a lot of knowledge. They may have a lot of skill, and those are different. But I do think it's setting structured expectations. I can give you sort of my own examples of what I've done in the past. I've had several students who have been exceptional. Ironically, Mark Milligan was one of those. You guys know him pretty well. He and I were in clinic together for a while. But those types of students who are driven, they're motivated, they're willing to eat the frog, right? They're willing to do whatever has to get done. They're willing, to get better. Those students, providing them additional structure, providing them additional hurdles. For example, if a student has been able to write my daily notes and eval notes, they've been able to be in the exam room with me and have seen me clear the body chart and go through the past medical history, past surgical history, special questions, identifying mechanism of injury, and can clearly articulate the primary, competing, and complicating hypotheses so that we can talk about what are the required steps going into the objective exam. If they can do that repeatedly, then the next step is good. Now, go and do it without me with this next due patient, and then bring me into the room and talk to me about what you found in front of the patient. And so the next step would be the intern would go into the exam room. And one of the things I really believe is that we can change the expectations and mitigate what I call the intern effect with some real simple steps. Because patients don't want to see students. I mean, especially they don't mind. They're kind. They're willing to help somebody. But doggone it, my back hurts, and this is costing me a bunch of money because the deductible's high, and I intend on getting better. So oftentimes we'll have the intern go in and simply say, hi, my name is Jeff. I'm a physical therapy intern working with Dr. Bennett. And I ask them to use my title so that the patient knows sort of the actual guys coming in or the actual gals coming in just a few minutes. And it's not unlike when the nurse comes in to take the blood pressure or get the vitals before the doctor comes in a traditional medical setting. So the context is similar to those patients. So Dr. Bennett will begin in just a minute. He's asked me to get started with a few questions before he comes in. All right, so that basically is able to set the stage for the interaction to occur. And the patient's kind of like really not all that threatened or it doesn't feel like they have to sort of unload their story very, very quickly. And it actually creates space for the intern to navigate the process. So the intern will go through and they'll get the body chart and they'll go through the past medical, surgical history and the process that we've outlined. And then they'll say, great, we're all ready. Let me go get Dr. Bennett and let him know we're ready for him. Right? So essentially there's this, okay, I've got all this information. Let me go get the physical therapist. Well, then I'll come in and introduce myself and say hello. And then I'll turn to Jeff and I'll say, okay, Jeff, reminding he's the student, why don't you tell me about Mrs. Jones? And then Jeff launches into an oration of what he just did. Mrs. Jones is a 45-year-old female. She presents to the clinic today with a primary complaint of low back pain. She describes it as sharp, occasional ache. It's intermittent variable. Its aggravating factors are this thing over this much time that brings her pain up to this level. The other one is aggravating this activity over this much time, brings it up to this much pain level. The easing factors are this activity with this much time, reduces it to this pain level. Here's the other easing factor. She also records, and it goes through the rest of the body chart, and then he'll flip the page over and go, and her past medical history was consistent for this. We found this in her special questions. She reports that she's pre-diabetic. Her A1Cs are at 5.9. Her next follow-up with his primary care around her diabetes is in 3 months. And her mechanism of injury is this. And so and then he finishes up the oration. The patient looks at him and goes, "Holy cow! Holy smokes! I had no idea that you were paying attention to me or that you knew those things." And what you do is you build efficacy in the intern. And then the intern begins to feel it. The intern begins to go, yes. And then depending on where they are in the process, you can ask the intern, you can say, okay, great. So what do you think your primary hypothesis is? What are your competing ones that we need to rule out in the physical exam? And are there any complicating factors that you've identified? Great. And then depending on where the intern is in their abilities, I can step in. Part of that's based on time, right? It may have taken them a lot longer to get through that than it would an advanced clinician. So now we need to kind of like catch up real quick because this patient's been in the clinic for 50 minutes already. I can do the quick physical exam, get them in, start the intervention. Or if they've gotten better at their hypothesis-based reasoning, and now that it's down to a good, 20, 25 minutes to get to that point, then, and they've been deemed good enough on their physical exam skills with you that you can go ahead and have them run that. Then you can be in the room while they do the physical exam, or you can step out and say, great, go ahead and do that's right. It sounds like mechanical back pain. Yep, you're right. Let's do the slump. We're going to modify the lower quarter exam to defer the knee and ankle today. Why don't you grab that and then come get me when you're done? And so now essentially you're tethering and giving this intern more and more and more rope, but you're also checking in and allowing the intern to give to you a grand rounds format in front of the patient, and the patient begins to believe, wow, man, I am in the right place. If this is the student and this is the kind of care I'm getting, then I'm going to get much better.
Yeah, no, I love that approach. And I think that's one of the best ways that I've heard for a solid win-win-win for everyone on that one. Because that's definitely can be a delicate and tough situation, as some of the issues that you said before in terms of letting the intern or student do things. So I think that's an overall really good way to do that, because that would definitely solve a lot of problems. So, Andrew, I got to bring up one thing here that probably all students and all instructors absolutely love, and that would have to be the CPI. Now, I'm curious, I'm just really curious, kind of what are your thoughts overall on the CPI, and what are your thoughts on how we can perhaps make it better if you feel like we need to?
Yeah, it's. I mean, I get to stand on the sidelines and throw rocks at this thing because I have not been involved in developing it. I have not been involved in developing an alternative. So let's just preface my comments by, again, I'm on the sideline here. I just have to deal with it, and I think it absolutely sucks. I think it's an absolute waste of time. Now, again, we need something, right? I mean, it's clearly, we have to be able to provide some mechanized, standardized version that's basically a pass-fail. But the CPI is a joke. The amount of time that it takes for the student, the amount of time it takes for me, it's really, it's not my favorite tool. I will, again, refer that, I'm standing on the sidelines. I wasn't involved in developing it, and I haven't developed an alternative. So, I feel like I can throw rocks as long as everybody knows I'm on the sideline. I'm not in the middle of trying to develop it. The other, the thing that I do like is a quick assessment of the student's abilities of himself or herself against the abilities identified by the CI. I do think that's helpful, right? Because oftentimes it's not that oftentimes it's the differencing in those two that provides the obvious areas of feedback. Either the student classically underrates their abilities and the CI is rating them as higher, or there's an opportunity to say, hey, perhaps I've been giving you so much feedback about where you need to improve that I've failed to let you recognize how good you actually are, right? So sometimes wanting to be better and constantly providing feedback can be interpreted as never good enough. So you can balance those a little bit in your feedback. In terms of the skills assessed by the CPI, that's no. I think my personal bias is, the students are being asked to be safe, and they're being asked to be marginally effective, right? I mean, that's the goal. It's low, but the goal is that, yes, this student is ready to sit for the board exam and will not be a threat or a menace to the public. I mean, that's what our licensure exam is set up to be, right? It's protection of the public. It has nothing to do with how good you are. So when we look at getting feedback to students, I really feel like it ought to be, are you safe? And do you have a basic structure of how to engage patients? Now, that's the low end of the bar, right? If you're not meeting that, then you don't need to pass go. You don't collect $200. You done. You don't get to go forward. But to try to take a tool like a CPI and use that for providing feedback and developing and growing, there are way too many variables of the comfort level of the CI giving harsh or difficult feedback, honest and uncomfortable, the willingness of the student to take ownership and responsibility for their own growth. Are you looking at tacit skills like time management, communication, body language, multitask management, engagement with support staff, or are you looking at specifics of, clinical reasoning and rubric? It's way too complex to have one specific thing. So I think it ought to be linked more to, an outcomes database. Look, here's in the 10 weeks that you were here, you saw 3 low back pain patients from, start to, marginally finish, and you've got, you've achieved the MCID on the oswestry. Great. Then basically you're doing okay. Anyway, that's my bias. So CPI, not my favorite tool.
Interesting. No, that's a very interesting. I really like that idea at the end and really trying to relate it more to outcomes, because I think that would definitely, at least for me, that probably might hit home a little bit more kind of if I was a student. So Andrew, I got to ask, in your opinion, what features constitute a top-notch clinical instructor?
What features constitute a top-notch clinical instructor? I think humility, being willing to be wrong in your own teaching approach, right? Being willing to recognize that while you may have identified the area that needs to grow, that you've got to be able to shift and adjust your own teaching abilities to meet the needs of the other. Because at the end of the day, it's about them, not about you. So humility is a requirement. There's got to be a passion. There's got to be a hunger, right? There's got to be a desire to do the extra work and spend time in the extra conversations and being willing to dive deep into areas that perhaps your daily schedule doesn't exactly allow. So you get to create time to teach. There definitely has to be a hunger. I think an excellent skill set in communication can really make or break a good CI. We talk about social and emotional intelligence. What are those skills like? Are you able to read the room and identify where the patient is and where the intern is and where your support staff is and where that other patient is that you're managing while the student is managing their own? Those social emotional intelligence skills are very, very important. So if I had to summarize my thoughts, it would be humility, passion, communication, and emotional integrity, emotional maturity.
Yeah, that's a great take, Andrew. I think as I've grown in my own practicing, I've noticed that it's definitely okay to be wrong, because if you're wrong, at least you're learning.
In fact, yeah, one of the I always kind of chuckle when the first time a student gets a patient back and they're worse, right?
Yeah.
And they're freaking out. Oh my God, I made them worse. Their knee's terrible, or their back is worse, their nerve pain's worse. And I always chuckle and I go, "That's great."
Yep, we learned what not to do.
Well, and more importantly, you've identified where the problem is, right? So the idea is, if I intervene at X and I make a change, better or worse, I'm in the right area. Congratulations. It goes back to the code breaker, right? I got the right color. It's just in the wrong place.
Exactly. So, Andrew, what would you say are some of the current limitations or struggles of being a clinical instructor? And what do you think needs to be done in order to best manage these struggles?
Well, I will tell you, I think these rotating internships every 6 to 8 to 10 to 12 weeks is a waste of time. If you're looking at simply having a student be exposed to a clinical environment, that is an appropriate tool. But if you're expecting an intern to actually learn basic proficiency, they need to be in those locations for much longer. My preference is a minimum of 6 months. And I will tell you, in my own practice, I've stopped taking any students who will not in our facility for 6 months or longer. I just am not interested in pouring that much energy and effort into a 6-week or a 10-week rotation when I've got students and programs who are willing to let them combine certain intern, depends on their academic calendar, for 6 to even 9 months. When we were working with the Army Baylor program, it was a 9-month program. South College, the new Baylor program, those are 6 months. There's I was trying to think, at Paul Mencken School, Colorado, those are 6 months. Those are fantastic, where we're able to really invest in those interns, help them get a solid proficiency around flow and process, and then, like as we've talked about earlier today, giving them tools to be successful. But yeah, I think that the timeline is a killer. Absolutely.
Yeah, no, and that actually makes a lot of sense. And Andrew, for my next question, you kind of answered part of it before when we were talking about how to handle the gifted student. Because as we know, with the clinical pressures for outcomes and also to maintain relationships with referral sources and the clinic reputation, sometimes it is challenging to kind of set up a safe space for the student to fail and learn, with the risks of failure causing problems at the clinic. And I know you touched on one of these aspects before, but are there any other recommendations that you would recommend for CI to best facilitate the best clinical learning environment for the student, to kind of help also avoid potential backlash to the clinic?
Yeah, so there's a couple of steps, I think. One, the intern doesn't know what they don't know. So you can't hold them accountable for knowing what they don't know. You can hold them accountable for not knowing what they are supposed to know. But often it's not knowing what they don't know is where you get into the customer service failures or the relationship failures or stories get, start to spin out of control. Or I never saw the PT, I only saw a student, right? I mean, that's a CI's nightmare when you're talking about managing referral sources and relationships. So one of the things I think is important is to recognize that the CI's role is to validate the intern and to elevate the clinical experience, right? That should be the mantra of every interaction. Now, you can validate that the intern is wrong and still elevate the clinical experience. I'll give you an example. A young student was in my clinic. He was very limited in his examination skills, his history skills. Patient came in with some what looked like, IT band or patellofemoral style knee pain. Student screened the hip, but completely neglected to screen the lumbar spine, which was pretty easy to pick up in some of the history. But it is part of, the slump and SLR are part of a standardized exam, and he totally missed it. So he comes to bring me in and he tells me the history and he tells me what he did in the physical exam. And so he believes that it's patellofemoral pain and it simply needs a little bit of VMO strengthening and needs some lateral stretching, yada, yada, yada. And in my head, you're going, dude, you totally missed the slump and SLR and you need to screen these. And besides, the guy's got these other symptoms that you're not paying attention to. But you don't go in there and say, no, you're wrong. You've missed X, Y, and Z. Because if you do, you don't validate the intern, you mess up the patient-intern interaction, and you don't elevate the clinical experience. The response to this is yes and. Yes, he does have some patellofemoral pain. And in this type of patellofemoral pain, you can often intervene at the lumbar spine, and it'll make the patellar pain get better even faster. Let me show you. Sir, put your hands behind your back, slouch your head over, bring your leg. Look, you see, this is called, what test is this called? The intern goes, oh my God, this is called the slump test. You're exactly right. Yeah. And here's how the slump test can show us. You see how that reproduces his knee pain? Great. Now, let's go ahead and intervene at the back. Now sit back up. The slump test is different. Now, what was the test you used to identify his patellofemoral pain? Oh, I used a squat. He could only squat 15 degrees before his knee pain. Why don't you check it again? Oh, look, it's 50 degrees of squat before his knee pain. Yes. Do you see how in this type of patellofemoral knee pain that you're treating, this little piece can make this better? Right? So you take a yes and approach, not an either or. And by doing that, if you you just maintain your focus on the mantra of validating the intern and elevating the clinical experience, then it creates that third win.
Yeah, I think that's a really great way to create a safe learning kind of place for the student, because the last thing you want to hear in front of anybody, whether it's colleagues, patients, or other students, is no, you're wrong, or no, you didn't do this right. Like you said, validate and then add some other helpful pointers. I love that. That's a great method. Andrew, I'd like to know a little bit about you personally. How do you feel you've changed as a CI from when you started to where you're at now? And what aspects are you noticing that you're currently still developing as a clinical instructor?
How long is this podcast again? Yeah, man, that's a holy smokes. Golly, so much has changed. Scott, I don't think I ever stopped changing. I think constantly being critical of my own teaching style, looking at the effect of my interactions. One of the things that I really use is an approach of, if I'm right, it looks like X. Right? So whether it's clinically or whether it's instruction, if I'm right, if I'm able to get student Jim to be independent here, it looks like this. Or if I'm able to, and so you define the outcome, and then, you're systematically wrong, right? Okay, my best guess is I do this, and I'm going to do it really well, and then I'm going to compare it to my defined outcome. Nope, I'm not moving the needle. So let me be, clear that this particular approach with this student is not working. So then I have to abandon that and shift. Gosh, my communication skills changed. I'm constantly reading, looking at, better understanding of my nonverbals, better understanding of managing the patient in the conversation. There's a great book called Managing the Arc of the Conversation. Very, very helpful. It's actually a sales book, but it's really helpful. What am I noticing now? Let me just see if I can kind of parsec your question here. So what am I noticing that I'm doing now that I wasn't doing in the earlier years? I think the biggest thing I'm doing now is I am not projecting my version of success on my interns, right? Like they get to define what success is, not me. My hope is that I create a hunger for learning, right? My hope is that I develop an understanding that there is an answer and that there is a process for getting better. My goal is not to get them better or get them good. And so that I would say that's changed dramatically. I used to, when an intern would come in, I would be like, rubbing my hands together like, okay, here we go. We got to get you from point A to point B and I'm the guy to make it happen. That's so arrogant. That's just not true. You can think that. You can certainly take that energy on, but that is going to be a energy suck. It's going to be a time suck, and that puts you in the place of the CI of being, sort of all knowing and saying what success really is. But what does success look like for that intern? What does success look like for this particular situation? And being willing to look at something that might be less than my preference as success for that intern.
Wow. No, I think that's a very powerful take. And I think that's, it's funny that you say that, because as soon as you said that the initial that, this is what I'm going to think, this is what I'm going to help them get to, I think that's like, at least for me, that's kind of the initial mindset I thought of as well. And, with me not having a student yet, it's really empowering to hear you say that, because now I'm going to totally look at that a different way. So thank you for helping me save a lot of error in the beginning.
Yeah, for sure, Brandon. I would say that's probably been the most difficult and probably the most profound change for me is really recognizing that I'm not the guy with the answers, and I'm not going to be able to solve, fix, change, develop, whatever you want to adjective, you want to put in the blank there. Of my goal is to facilitate learning. My goal is to help create and foster that fire within the intern, and the recognition that there are people, there are good clinicians in this world who don't have the eat, sleep, live, breathe PT mantra in their head. What we do is not who we are, and let's not foster that belief.
Yeah, no, that's very powerful. And and Andrew, you mentioned a couple of these things before, between the book that you mentioned and a couple other things prior. But what other resources have you found useful to kind of help develop as a clinical instructor?
Okay, a couple of things. One, there's a great tool. It's actually built for business. It's called situational leadership, and situational leadership allows you to identify one of 4 quadrants that a particular scenario exists, and the style of leadership that can be matched to that particular situation, right? So not to people, people aren't the situations, but people are in situations, and you manage them that way. Situational leadership it's very easy to transition that over into teaching. Those of you that may be not as familiar with it, the 4 quadrants are 1 through 4, and 1 is sort of this lowest level of learner, where you need a high direction and very low emotional support for that individual. This is sort of hey, if you want me to teach you, you got to earn my time. Here's how you write my notes. You click here, you click here, you click here. I don't care if you like it. I don't care if you agree with it. I really don't care. Right? So there's very low emotional support and a high direction. At a low novice level of learning, that's appropriate. moving to the next group, then though that you can't always be there. There's a more directive approach with some emotional support. So here's how you're going to do the historical exam, but the emotional support comes in. But here's why. Here's how this works, right? And then it progresses across the other two quadrants. But situational leadership, I did a YouTube video. I'll have to look for it. It's somewhere, where I was teaching a group of lab instructors how to be effective lab instructors, and I outlined it. So I'll find that, Scott. I'll send that to you if you want to link to it somewhere. Other thing I think has been helpful is, really understanding the intent behind what you're doing. Do nothing for no reason. If you're having your intern do something, have a reason for it. If you're having your intern not do something, have a reason for it. If you're modeling an interaction, have a reason for it. And being able to clearly define the question that you're answering. I think those are all good practices. In terms of other resources, John Maxwell is a great author. He's one of my favorites. He wrote a book that's called Everyone Communicates, but Few Connect. It's a great read. And I think it's one of those that has some real tangible resources in it for developing communication skill. We talked about that, managing the arc of conversation already. Situational leadership, we've mentioned that, by Blanchard and Hershey. And then just practical thoughts. Of just having some good structured things in place for what you want to learn, like how you want to teach, right? We talked about having the process for the historical exam, having the process for the physical examination. I think having those written down, even put them on YouTube so that they have an idea of what's expected of them. Those can all be helpful.
Yeah, no, that's absolutely great. And I think that's something that's very helpful, because those are definitely some resources that I'm going to take a look into. And what I will also do is I will post these links to the resources that we find in the show notes for any of our listeners that kind of want to look into this as well, so you guys can have that. And Andrew, thanks so much for coming on the show today, as we've both certainly learned a lot. And to me, this has been absolute gold in terms of giving me a different way to consider things starting out as a clinical instructor, because I think this is really going to make a big difference so that I don't make so many big errors early on. So I can't tell you how much I personally appreciate that. And I'm sure that there's many of our listeners that are going to be in that same or similar situation as well. And, we normally like to ask this last question to each of our guests at the end, because we're always so curious what everyone's thoughts are. And the question is, if you could change one aspect of healthcare education, whether that be DPT or other healthcare provider related, which aspect would you change and how would you change it?
Well, I'm going to be real blunt. We already are. Through our involvement with South College and Baylor and Evidence in Motion, we're reducing the tuition cost by a third by taking the 3-year DPT and bringing it down into 2. We're getting rid of these ridiculous 6, 8, 10-week rotations and putting them in 6-month terminal internships. And we're fostering a culture that's being driven towards board certification by having them really engage in commitment to postgraduate residencies. So I think through the leadership of John Childs and the like, Tim Flynn, obviously Larry Benz, those things are already happening. If I could add one little piece to it, it would be through the clinical interface that we've talked about today. Building clinical instructors who are systematically good at being wrong, and building their students to be thinkers. God, if we could just teach them to think.
Yeah, that's a great take, Andrew. I love that. The problem is, I feel like that thinking process should be addressed way earlier in the learning process. Like I say, even as young as high school. I don't know, how we're missing the boat so many times in creating clinical thinkers. I mean, it just blows my mind. And then once you have a foundation in clinical thinking, and clinical reasoning, the critical thinking aspect can be applied anywhere. It doesn't have to just be PT school. So I don't understand, how we're missing that boat. But, you would figure college should get them ready for that, but it just doesn't.
No, it doesn't. In fact, my wife and I we homeschool our kids. Well, all but one of them. My oldest is in a high school, but very much fostering that thinking process early on. I mean, it starts way early. That the recognition that there are choices, the recognition that you have to think, the recognition that it's not a push button world. You push a button, you get a response. Well, fostering that is hard. I don't believe it is the responsibility of the PT schools to teach these individuals how to think.
Yeah. Well, Andrew, can't thank you enough for your time and for coming on this morning. It's been a great chat. Where can people find you online and on social media if they want to follow up?
Sure. I'm on Twitter. I'm Bennett AB. Then on Facebook, you're welcome to look me up by my email address, andrew@texpts.com.
Awesome. Well, Andrew, again, thank you so much for coming on all the insight, and wish you have a good rest of your day with everything, man, and always a pleasure.
Thanks, guys. It's been a blast. I appreciate the invite, and thank you for what you're doing to push this information out to make us better in healthcare.
That's all our goal. No, and it's thanks to people like you that are actively doing it and willing to give their time. So the thanks is all to you.
Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter @HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.